Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 287 of our pharmacotherapy series, which majors in thrombosis. The first question reads, SAW is a 52-year-old, 70-kilogram woman. She recently returned from a 12-hour car ride where she only stopped to stretch twice. Yesterday she noticed a swollen right calf that is painful and warm. This swelling gradually increased, affecting the entire right leg to the groin, and prompted her to seek medical attention. In the emergency department, she also notes the recent onset of right-sided pleuritic chest pain without shortness of breath or hemoptysis. Her medical history includes a gastric ulcer 4 years ago, treated with proton pump inhibitor therapy, that has not recurred. Physical examination reveals an enlarged right leg and moderate tenderness in the entire leg. Chest examination reveals labored respirations, equal breath sounds, and no wheezing or crackles. Vital signs include a blood pressure of 160 systolic 90 diastolic, a heart rate of 100 beats per minute, and respiratory rate, 28 breaths per minute and regular. Laboratory data include the following: hematocrit of 26.7%, serum creatinine of 1.1 mg per deciliter, arterial blood gases, on room air PO2 of 72 mm of mercury. The normal range is 75 to 100 mm of mercury. PCO2 of 30 mm of mercury. The normal range is 35 to 45 mm of mercury. pH of 7.48. The normal range is 7.35 to 7.45. Chest CT shows a pulmonary embolism in the distal right main pulmonary artery extending into the right lower lobe. The electrocardiogram shows sinus tachycardia. The lower extremity duplex ultrasound is positive for acute occluding thrombus from the right femoral vein all the way down to the soleal vein. Coagulation test results include the following: prothrombin time of 11.2 seconds with an INR of 1. Activated partial thromboplastin time of 28 seconds. Platelet count of 248,000 per microliter. So my question to you is, what subjective and objective evidence in SAW is consistent with pulmonary embolism? Let's begin with the signs and symptoms. The clinical diagnosis of pulmonary embolism is often difficult to make because of the non-specificity of symptoms. The most common symptoms of pulmonary embolism include tachypnea, cough, substernal and pleuritic chest pain, dyspnea, hemoptysis, fever, and unilateral leg pain. Signs and symptoms such as hypotension, tachycardia, presence of B-type natriuretic peptides, abbreviated as BNP, or NT-proBNP, an abbreviation of N-terminal, pro-brain natriuretic peptide, troponins, I or T, hypoxia, and electrocardiogram changes suggestive of right ventricular strain are important to recognize, as these may indicate more severe thromboembolism and increased risk for 30-day mortality. Deep vein thrombosis precedes pulmonary embolism in 80% or more of patients. A combination of these signs and symptoms provides further evidence for acute pulmonary embolism. We will now look at a few definitions. There are varying ways to define the severity of a pulmonary embolism. Some define pulmonary embolism based on a patient's in-hospital or 30-day risk for mortality, whereas other literature will cite terms such as massive and submassive pulmonary embolism. Low-risk pulmonary embolism is classified as the presence of thromboembolism without changes in hemodynamics, right ventricular function, or cardiac biomarkers. These types of patients can also be classified as small to moderate pulmonary embolism. High-risk pulmonary embolism is defined by the presence of shock, manifesting as tissue hypoperfusion, and hypoxia, cool clammy extremities, alterations in consciousness, or hypotension, specifically defined as a systolic blood pressure below 90 mm of mercury or an equal to or more than 40 mm of mercury drop in systolic blood pressure for longer than 15 minutes, which is not attributed to new-onset arrhythmia, hypovolemia, or sepsis. These patients can also be classified as having massive pulmonary embolism. Patients with right ventricular dysfunction characterized by echocardiographic evidence or by positive cardiac biomarkers, that is BNP above 90 picograms per milliliter or NT-proBNP above 500 picograms per milliliter, troponin I above 0.4 nanograms per milliliter, troponin T above 0.1 nanograms per milliliter, are classified as having submassive pulmonary embolism if they are hemodynamically stable. We will now look at the diagnosis. Because the clinical signs and symptoms of pulmonary embolism are difficult to distinguish from many other medical conditions, further evaluation is necessary. Chest radiograph (ECG) and arterial blood gas, alveolar arterial oxygen gradient abnormalities are often present in patients with pulmonary embolism, but like clinical signs and symptoms, they are somewhat nonspecific. Pulmonary imaging is necessary to diagnose or definitely rule out pulmonary embolism. Although many methods are clinically available for chest imaging, the computed tomographic (CT), pulmonary angiography and ventilation perfusion lung scanning (VQ scan) are the most common tests used for the diagnosis of pulmonary embolism, with the multi-detector CT, abbreviated as MDCT, being the imaging test of choice because of its ability to visualize the pulmonary arteries in the greatest detail. Lung scans that incorporate an assessment of perfusion, or regional distribution of pulmonary blood flow, and ventilation are referred to as VQ scans. They involve both the injection and the inhalation of radio-labeled compounds. Test results are expressed as a high, intermediate, or low probability of pulmonary embolism. When ventilation air movement is normal over an area that shows abnormal perfusion blood flow, a VQ mismatch exists, and pulmonary embolism is highly probable. If a match defect is noted, abnormal ventilation over an area of abnormal perfusion, another disease state, such as chronic obstructive airway disease, is more likely. As in the case of deep vein thrombosis, clinical assessment of pulmonary embolism can improve the diagnostic accuracy of non-invasive tests such as CT, MRI, or VQ scanning. Validated assessment tools can be used to stratify a patient's probability of a pulmonary embolism. In patients with a low clinical probability of pulmonary embolism, measuring a high sensitivity D-dimer can be considered, and, if negative, pulmonary embolism can be ruled out, eliminating the need of further imaging studies. In patients with a moderate to high clinical probability of pulmonary embolism, diagnostic imaging studies should be performed. The next question reads, what anticoagulant strategy should be initiated for SAW? When the diagnosis of pulmonary embolism is suspected, anticoagulation should be initiated immediately while awaiting results of more definitive diagnostic procedures. There are several agents that can be used for the acute treatment of pulmonary embolism. IV unfractionated heparin therapy initiated with a loading dose followed by continuous infusion was the mainstay of therapy for many years. Alternatively, subcutaneous unfractionated heparin can be used. However, if there is a concern about adequate subcutaneous absorption or in patients in whom fibrinolytic therapy is being considered, initial treatment with IV unfractionated heparin is preferred to the subcutaneous route. Low molecular weight heparins are non-inferior to unfractionated heparin in the management of pulmonary embolism and are recommended over unfractionated heparin in stable pulmonary embolism patients because of their ease of use, less major bleeding, and ability for outpatient management or early discharge. Fondaparinux demonstrated non-inferiority when compared with IV unfractionated heparin for rate of recurrent pulmonary embolism, with similar rates of major bleeding. More recently, the direct oral anticoagulants have been evaluated for both the initial and long-term management of venous thromboembolism, with dabigatran, rivaroxaban, apixaban, and edoxaban all FDA approved for the initial management of pulmonary embolism. All of the direct oral anticoagulants were compared to low molecular weight heparin or vitamin K antagonists and found to be non-inferior for the rate of recurrent venous thromboembolism. Rivaroxaban and apixaban were studied as monotherapy, whereas dabigatran and edoxaban patients were initially treated with at least 5 days of parenteral therapy prior to receiving a direct oral anticoagulant. If SAW is being kept in the hospital for observation because of the severity of her symptoms, unfractionated heparin therapy could be started at a loading dose of 5,600 units, that is, 80 international units per kilogram multiplied by 70 kilograms, followed by continuous infusion of 1,300 units per hour, that is, 18 units per kilogram per hour multiplied by 70 kilograms. Monitoring of the activated partial thromboplastin time would be used to adjust dosing to maintain treatment within the therapeutic range. Alternatively, subcutaneous low molecular weight heparin 70 mg every 12 hours, that is 1 mg per kilogram every 12 hours multiplied by 70 kg, or subcutaneous fondaparinux 7.5 mg daily may be given while transitioning the patient to warfarin. SAW could receive fixed-dose enoxaparin 70 mg subcutaneously every 12 hours, dosed at 1 mg per kilogram every 12 hours multiplied by 70 kg, or dalteparin 15,000 international units subcutaneously every 24 hours, that is 200 international units per kilogram, rounded to nearest syringe size. Use of initial therapies such as low molecular weight heparin, fondaparinux, and direct oral anticoagulants allows for outpatient therapy and early discharge in hospitalized patients with acute pulmonary embolism. For patients with low-risk pulmonary embolism and home circumstances that are adequate, early discharge is suggested over standard discharge. Fibrinolytic therapy reverses right ventricular dysfunction and restores pulmonary perfusion more rapidly than anticoagulant therapy alone. It is generally reserved for patients with a high risk for mortality and a low risk for bleeding. Percutaneous catheter-directed treatment provides localized delivery of fibrinolytics to the pulmonary thrombi and is an alternative invasive method for removal of pulmonary emboli. It is a less invasive approach compared to surgical embolectomy in patients who are not candidates for systemic fibrinolytic therapy. For patients with moderate to high-risk pulmonary embolism, catheter-directed thrombolysis has emerged as a promising option for patients who would also be candidates for systemic fibrinolytic therapy. The next question reads, if SAW is to start on warfarin, rather than a direct oral anticoagulant, when should it be administered, and how should the transition from injectable anticoagulant therapy be accomplished? As in the treatment of deep vein thrombosis, if warfarin is to be started, the use of heparin, low molecular weight heparin, or fondaparinux therapy for pulmonary embolism treatment should be continued for at least 5 days and until warfarin therapy is therapeutic for at least 24 hours. Warfarin should be started on the first day of treatment and continued for 3 months, or longer if indicated. However, a delay in the initiation of warfarin may be acceptable in the setting of an anticipated extended hospitalization, recent or anticipated surgery or other invasive procedures, or a medical condition with the potential for uncontrolled bleeding. There are several reasons to overlap heparin or low molecular weight heparin or fondaparinux and warfarin therapy. The onset of warfarin activity depends not only on its inherent pharmacokinetic characteristics, half-life longer than 36 hours, but also on the rate of elimination of circulating clotting factors. Although warfarin inhibits production of the vitamin K-dependent clotting factors, previously synthesized clotting factors must be eliminated at rates that correspond with their elimination half-lives. Approximately 4 half-lives are required for these factors to reach a new steady state after their production is inhibited, so the effect of warfarin can be delayed for several days. Initial increases in the INR reflect only reductions in factor VII activity, but full anticoagulation with warfarin requires adequate suppression of factors 2 and 10, which have significantly longer elimination half-lives. By overlapping a quick-onset injectable anticoagulant such as heparin or low molecular weight heparin or fondaparinux with warfarin therapy, adequate anticoagulation can be continued until warfarin therapy reaches a therapeutic intensity. In addition to suppressing the synthesis of the vitamin K-dependent clotting factors, warfarin also inhibits the formation of the naturally occurring anticoagulant protein C and its cofactor, protein S in patients with congenital protein C or protein S deficiency. Initial warfarin therapy can suppress these proteins to concentrations that may result in hypercoagulability with possible thrombus extension, unless concurrent heparin therapy provides adequate anticoagulation. To prevent these complications, heparin or low molecular weight heparin or fondaparinux and warfarin therapy should overlap. Heparin therapy has been observed to prolong the INR and warfarin can prolong the activated partial thromboplastin time by several seconds. Thus, interference with laboratory tests should be considered in the evaluation of the intensity of anticoagulation during the overlap of heparin and warfarin therapy. The next question reads, in an effort to discharge SAW from the hospital as soon as possible, an initial dose of warfarin 10 mg orally every evening for 3 days has been ordered. Is such a loading dose reasonable? What are more effective approaches to initiating therapy? Initiation of warfarin dosing is complex because dosing requirements vary significantly among individuals. Daily doses as low as 0.5 mg and as high as 20 mg or more may be required in individual patients to reach a therapeutic INR. 2 primary methods for initiation of warfarin therapy are used. The average daily dosing method relies on an understanding that although dosing requirements for warfarin vary significantly among patients, an average dosing requirement of 4 to 5 mg per day of warfarin is necessary to maintain an INR of 2 to 3 in most patients. When average daily dosing is used for initiation of warfarin therapy, patients are typically started at 4 to 5 mg daily, with dosing adjustments as necessary until the therapeutic goal is reached. However, patients who may be more sensitive to the effects of warfarin are expected to require lower dosages of warfarin. In these patients, therapy should be initiated at 1 to 3 mg daily, with subsequent dosing adjustments as necessary. Several dosing algorithms, using a 4 mg to 5 mg initiation dose, have been developed to aid with dosing decisions after the first few doses of warfarin have been administered. Another popular dosing algorithm recommended by the American College of Chest Physicians (ACCP) for outpatients uses a 10 mg initiation dose for the first 2 days, with the INR on day 3 measured to guide dosing on days 3 and 4, and the INR on day 5 used to guide the next 3 doses. Although using this dosing algorithm helps achieve a therapeutic INR more quickly than using a 5 mg initial dose, these findings may not be generalizable to all patient populations because the patients evaluated were relatively healthy, young outpatients. The 10 mg initiation dose may lead to over-anticoagulation and heightened bleeding risk in elderly and ill patients with multiple medical problems. Average daily dosing is often used to initiate therapy in ambulatory patients. In this case, the first INR should be evaluated within 3 to 5 days of initiation of warfarin therapy. In hospitalized patients, it is more common to evaluate the INR daily during initiation of therapy. Flexible initiation of warfarin is an alternative approach for starting therapy that is based on evaluating the rate of increase in the INR and making daily dosing adjustments based on daily INR evaluation, with the goal of determining the eventual maintenance dosing requirement. Using this nomogram, warfarin can be initiated with either a 10 mg or a 5 mg starting dose, with daily dosing adjustments based on the rate of increase in the INR. Flexible initiation does not necessarily shorten the time to reach the goal INR, and initiating therapy with a 10 mg dose as described in some protocols may be associated with an increased risk of early over-anticoagulation in certain patients. Nonetheless, these methods offer a more individualized approach to initiation of therapy. The baseline INR for SAW was 1. Using the flexible initiation protocol, the first dose of warfarin should be 10 mg administered in the evening on the first day of hospitalization. Subsequent INR values obtained daily will guide dosing requirements until a therapeutic INR is reached. The order for warfarin 10 mg orally every evening for 3 doses should be discontinued and replaced with daily orders for warfarin and INR monitoring. The next question reads, what is the goal INR for SAW and how long should anticoagulation be continued? In patients with deep vein thrombosis or pulmonary embolism, warfarin doses that prolong the prothrombin time to an INR of 2.0 to 3.0 are defined as regular intensity therapy. This therapeutic range is recommended to maximize the antithrombotic effect of warfarin while minimizing potential bleeding complications associated with excessive anticoagulation. Once formed, venous clots adhere to the blood vessel wall. Thus, the first step in resolution of a thrombus involves covering the clot with a layer of endothelial cells to prevent additional platelet aggregation at the site of vessel injury. This endothelialization process generally takes 7 to 10 days to be completed. Initial anticoagulant treatment is used to prevent clot extension while allowing adequate endothelialization to occur. Continued anticoagulation prevents further clotting. The appropriate duration of warfarin therapy is based on the likelihood of a recurrent venous thromboembolic event and the risk of bleeding in each patient. Patients with unprovoked, idiopathic, deep vein thrombosis or pulmonary embolism should be treated for at least 3 months, but considered for indefinite therapy as their likelihood of having a recurrent event can be as high as 30% over 5 years. Patients with deep vein thrombosis or pulmonary embolism associated with transient or reversible risk factors, provoked venous thromboembolism, are usually treated for 3 months, as in the case of SAW, whose venous thromboembolism provoking risk factor was a prolonged car ride, as the risk of recurrence is lower, approximately 10% over 5 years. In cancer-associated thrombosis, first-line treatment consists of long-term low molecular weight heparin based on improved clinical outcomes over warfarin. However, this needs to consider individual patient bleeding risk, patient preferences, tolerability, and drug costs. The use of direct oral anticoagulants in patients with cancer is not currently endorsed. However, current data support its safety compared to other options. The next question reads, what possible adverse effects from oral anticoagulation therapy should be considered in SAW and how should they be monitored? Let's look at hemorrhage. Bleeding is the most common adverse effect associated with anticoagulation. A summary of experimental and observational inception cohort studies determined that the average annual frequency of fatal, major, and all, that is major or minor, bleeding in patients treated with warfarin was 0.6%, 3%, and 9.6%, respectively. However, wide variation in bleeding frequencies has been reported, likely due to differences in patient characteristics, treatment protocols, and the definition and assessment of bleeding among trials. The most common sites for anticoagulation-related bleeding are the nose, oral pharynx, and soft tissues, followed by the GI and urinary tracts. Hemothrosis, that is bleeding into joint spaces, and retroperitoneal and intraocular bleeding represent less common hemorrhagic complications of anticoagulation therapy. Gastrointestinal and urinary tract bleeding in anticoagulated patients is often caused by previously undiagnosed lesions. Menstrual blood flow may also be increased and prolonged in women taking anticoagulants. This problem may be clinically significant if there is an underlying pathologic condition, such as ovarian cysts, uterine fibroids, or polyps, resulting in abnormal vaginal bleeding. For venous thromboembolism treatment, the direct oral anticoagulants rivaroxaban and apixaban both showed significantly lower rates for major bleeding in clinical trials compared to warfarin, whereas edoxaban and dabigatran showed comparable rates. A recent meta-analysis demonstrated no statistically significant differences for efficacy and safety associated with most treatment strategies used to treat acute venous thromboembolism compared with the low molecular weight heparin vitamin K antagonist combination. However, it showed that the unfractionated heparin or vitamin K antagonists combination is associated with a higher rate of recurrent venous thromboembolism and that rivaroxaban and apixaban demonstrated a lower risk for major bleeding. For venous thromboembolism treatment, the direct oral anticoagulants rivaroxaban and apixaban both showed significantly lower rates for major bleeding in clinical trials compared to warfarin, whereas edoxaban and dabigatran showed comparable rates. A recent meta-analysis demonstrated no statistically significant differences for efficacy and safety associated with most treatment strategies used to treat acute venous thromboembolism compared with the low molecular weight heparin vitamin K antagonists combination. However, it showed that the unfractionated heparin-vitamin K antagonists combination is associated with a higher rate of recurrent venous thromboembolism and that rivaroxaban and apixaban demonstrated a lower risk for major bleeding. Although it is uncommon, intracranial bleeding resulting in hemorrhagic stroke represents the most common cause of fatal bleeding associated with warfarin therapy. Rates of intracranial hemorrhage associated with anticoagulants have been estimated to range from 0.3% to 2%, and up to 60% are fatal. The direct oral anticoagulants have been shown to be as effective as warfarin for stroke prevention in patients with atrial fibrillation and are associated with lower rates of intracranial hemorrhage and reduced all-cause mortality. However, all of the direct oral anticoagulants, except for apixaban, are associated with a 25% increased risk of gastrointestinal bleeding. Many factors influence the risk of hemorrhagic complications associated with warfarin. The frequency of bleeding is higher in the first 3 months of therapy than during subsequent months. Unlike heparin, the intensity of anticoagulation with warfarin directly influences the risk of bleeding, including intracranial hemorrhage. Other patient-specific variables that influence the risk of warfarin-associated bleeding include a history of GI bleeding, serious comorbid disease, including malignancy, and concomitant therapy with aspirin, clopidogrel, or nonsteroidal anti-inflammatory drugs, abbreviated as NSAIDs. Several bleeding risk scores are available, including has bled, an abbreviation of the hypertension, abnormal renal or liver function, stroke, bleeding, labile INR, elderly, drugs and alcohol, trial, and atria, an abbreviation of the anticoagulation and risk factors in atrial fibrillation, trial, which may identify patients at higher risk of bleeding. However, how best to use these tools remains in question. None of these bleeding risk scores have been very effective at predicting risk for major or fatal bleeding in the first 3 months of anticoagulation for venous thromboembolism, and none have performed well in the elderly in predicting major bleeding in the first 90 days of anticoagulation for venous thromboembolism. Bleeding complications in SAW can be minimized by careful attention to the signs and symptoms of bleeding by the patient and her caregivers, maintenance of the INR within the therapeutic range, avoidance of therapy with concomitant drugs known to increase the risk of bleeding or to increase the INR, and routine outpatient follow-up for INR monitoring and clinical assessment. Let's briefly look at skin necrosis. Warfarin-induced skin necrosis is a rare but serious adverse effect of oral anticoagulation, occurring in approximately 0.01% to 0.1% of patients treated with warfarin. Patients present within 3 to 6 days of the initiation of warfarin therapy with painful discoloration of the breast, buttocks, thigh, or penis. The lesions progress to frank necrosis with blackening and eschar. Skin necrosis appears to be the result of extensive microvascular thrombosis within subcutaneous fat and has been associated with hypercoagulable conditions, including protein C or protein S deficiency. In these patients, rapid depletion of protein C before depletion of vitamin K-dependent clotting factors during early warfarin therapy can result in an imbalance between procoagulant and anticoagulant activity, leading to initial hypercoagulability and thrombosis. Adequate use of injectable unfractionated heparin or low molecular weight heparin, or fondaparinux during initiation of warfarin can prevent the development of early hypercoagulability. Warfarin therapy should be discontinued in patients who develop skin necrosis. However, subsequent warfarin therapy is not necessarily contraindicated if it is required for treatment or prevention of thromboembolic disease. In patients with protein C or protein S deficiency and a history of skin necrosis, warfarin therapy can be restarted at low dosages if given with unfractionated heparin or low molecular weight heparin or fondaparinux. Therapy is maintained until the INR has been within the therapeutic range for 72 hours. Supplementation of protein C through administration of fresh frozen plasma also may be indicated. Next we will look at the purple toe syndrome. Purple toe syndrome is a rarely reported adverse effect that typically occurs 3 to 8 weeks after the initiation of warfarin therapy and is unrelated to intensity of anticoagulation. Patients initially present with painful discoloration of the toes that blanches with pressure and fades with elevation. The pathophysiology of this syndrome has been related to cholesterol microembolization from atherosclerotic plaques, leading to arterial obstruction. Because cholesterol microembolization has been associated with renal failure and death, warfarin therapy should be discontinued in patients who develop purple toe syndrome. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 288.